This presentation will focus on eating disorders, and they fall under the concept of self. These are the 3 eating disorders that we are going to focus on: anorexia nervosa, bulimia nervosa, and binge eating disorder. And even though they're classified as mental health disorders, eating disorders are super tricky to diagnose and treat, because not only are you having to look at the person's mental state and treat the eating disorder psychologically, but these eating disorders also can have severe physiological consequences that we have to treat as well. Eating disorders have been around for centuries, and they were first noticed during the Middle Ages, but they were not completely established as mental health disorders until about the 1960s and 1970s. That's when some of the actresses and athletes that were popular started developing these eating disorders and kind of brought them to light and shined a light on them, where they became studied more and people put more focus into actually learning how to treat them. Eating disorders do tend to run in families. There is a genetic component to it, and they may also be related to dysfunction of the hypothalamus or low levels of serotonin in the brain. On this slide, I've listed a few points about disordered eating. So we know that it's when someone will consistently consume calories that are way too much or way too little for what they need to maintain a healthy weight based off of their body frame. It's often accompanied by anxiety or guilt. It occurs without hunger, or the person may eat a lot and never quite feel satisfied. And it can result in physiological problems and medical complications that we will talk about more here in a bit. Let's briefly talk about risk factors. I'm sure some of these you guys will be familiar with because you know how things in the media and such can influence how a person feels about themselves. But let's just talk about all these for just a few minutes. So the first one is a genetic and environmental link. We mentioned on the previous slide that there is a genetic link to eating disorders, environmental as well. So things like growing up in an abusive environment may place a person at increased risk to develop an eating disorder. This can include things like physical neglect, sexual or emotional abuse. Bullying also puts a person at risk for developing an eating disorder. Their home and social environment. So when we look at people with eating disorders, we can kind of identify certain personality traits and certain home environments that link these clients to the disorder. So for people who have anorexia nervosa specifically, they may have excessively controlling parents. And this person may feel like they have no control over their life or no freedom. And one way that they can control their life is to control what they put in their mouth and what they eat. So they start to control their weight, start having extreme dieting, and that's the way that they can kind of bring control into their life for themselves. On the flip side, when they look at people who have bulimia nervosa, these clients sometimes have parents who have loose boundaries, or their family life may be quite chaotic, and this person might feel out of control in their circumstances, so that they try to control their eating habits to kind of bring a sense of stability to their life. Dieting in general can be a risk factor to develop an eating disorder, just because it might become out of control and the client may become obsessed with counting calories, and they might start losing weight and think, oh, this is great, I'm getting so many compliments, and it might become something that they become obsessed with. Cultural and media influences, that's kind of a no-brainer. We look at things on social media and how people can use Photoshop. People like to show off how they work out and how they diet, and that can influence people greatly, especially young people. It's been proven that living in a developed or industrialized country that favors and promotes a thin body type places its women particularly at risk for eating disorders. So places like the United States, Canada, Europe, Asian nations like Japan. And when people are constantly bombarded with TV, magazines, Instagram, social media in general, that just puts them at a higher risk for developing an eating disorder. Being involved in sports focused on body image, so sports like gymnastics, ballet, swimming, where we promote these athletes to have a very thin body type with low body fat, can put them at risk. For men athletes, like wrestlers and jockeys, they have also developed eating disorders too. So it's not just strictly women that this affects. And lastly, having another mental health diagnosis. People who have anorexia and bulimia, binge eating disorder, usually have some kind of co-occurring mental health diagnosis. Ones we frequently see would be obsessive compulsive disorder, depression, bipolar disorder is common in people who have bulimia, and substance abuse disorders as well. Anorexia nervosa is an eating disorder with symptoms that include a significantly low body weight, an intense fear of gaining weight or becoming fat, and body image distortion. These clients will severely restrict calories in order to maintain a low body weight. Some clients with anorexia nervosa only eat about 500 to 700 calories per day, or they may not even eat at all. And of course, if that's happening, malnutrition will occur as a result of these behaviors. Body image distortion is when a person has a lack of recognition of the seriousness of their low body weight, or they might have an unrealistic perception of their body size. So a person may see themselves as fat or unattractive, when in reality, that's not the case. And these people are very unhappy with their outward appearance. Some characteristics that are specific to anorexia nervosa would be that these clients tend to be perfectionist, and they tend to be quote unquote good children who don't really cause problems. They're typically your straight A, never get in trouble type people. They're extremely sensitive to failure and criticism. They really want to please others, and they try to avoid conflict. And as their disease progresses, they may become more socially isolated. So depression is a common co-occurring condition in clients with anorexia nervosa. They may be ritualistic when it comes to food. So what that means is they might be very strict about counting their calories. They might cut up their food in certain ways or only eat certain foods. They may have certain time of day that they eat their food, things like that. They're very ritualistic with what they do. They also have an early age of onset. Usually between 14 and 18 years of age is when you'll see anorexia nervosa come to light. 90% of cases of anorexia nervosa are in females, but like we mentioned before, it has been recognized in men, particularly male athletes like wrestlers. It has about a 7 to 10% mortality rate, and the clients with the longest duration of illness and the lowest body weights have the poorest outcomes. Anorexia nervosa is super hard to treat because these clients typically don't believe they have a problem. They don't think they're too thin. Remember, they have that body image distortion, so they're really not seeing what the outside world is seeing. And this can make them very resistant to treatment. And some studies suggest that only about 25% of clients with anorexia nervosa recover completely following treatment. So that's a super low number, and it's very unfortunate. This picture is a representation of body image distortion. So you see in this image that this client is seeing herself as larger than she really is. So a client may see themselves as overweight when in reality they are emaciated. The severity of anorexia nervosa is based off of a body mass index calculation, and a healthy BMI is between 18.5 and 24.9. Once you get below 18.5, that's when we start categorizing anorexia nervosa. So you can see mild, moderate, severe, and extreme. Obviously, extreme is the worst, and that would be a BMI of less than 15. Now let's talk about bulimia nervosa. This is when a person is going to engage in a binging and purging cycle. What binging is eating a large amount of food within about 2 hours, and it's larger than what most individuals would eat in a similar period of time and under similar circumstances. The client's going to feel a lack of control while they're binging, so they might just eat, and not be able to stop. They will feel like they don't have control to stop eating or control what or how much they're consuming. Purging is an inappropriate compensatory mechanism that rids themselves of the food that they ate. So these include self-induced vomiting, which is probably the most common one that you're familiar with. They may also misuse laxatives, diuretics, or enemas, or they may fast. And these are all done to prevent weight gain. These clients may choose to diet in between episodes of binging and purging. And to be diagnosed, these behaviors must occur at least once a week for 3 months. One difference between bulimia nervosa and anorexia nervosa is that people with bulimia nervosa may have little or no weight loss. Remember, we talked about with anorexia nervosa, these clients are going to be emaciated. They're going to be pretty small. You might not see that with people who have bulimia. This disease generally begins in late adolescence, so it's going to have a later onset than anorexia nervosa. Typically, your clients with bulimia are diagnosed between ages 15 and 24. This disease is more common than anorexia nervosa. And similarly to anorexia nervosa, it is more common in females than males. These are some behaviors you may notice in someone who has bulimia nervosa. I think the one we think about most commonly is people who may go to the bathroom after they eat meals, especially if they're doing it regularly right after they eat. They may eat large amounts of food in one sitting. That's what we talked about with the binging. Hoarding food. They may hoard food where people can't see it. Remember, we talked about that people who have eating disorders often feel guilty about them. That is particularly true with people with bulimia nervosa. They feel very guilty about their behaviors. So sometimes they'll hoard food in their bedroom. You might find wrappers under their bed. There was a story about a girl who had bulimia nervosa, and she said that she would go through a drive-through and order tons of food and binge in her car. And then she would hide the wrappers in her car so that no one would know that she had this disorder. So that's just an example. Exercising compulsively, you may or may not see that, and that would be a form of like a compensatory mechanism to avoid gaining weight. They may be depressed or anxious and irritable. Bulimia nervosa clients may act impulsively. So these would be things like maybe being promiscuous, spending money, stealing. These clients are more prone to have substance abuse disorders compared to people with anorexia nervosa. Anorexia nervosa clients want to be perfect. So they're not going to try to get into trouble or do anything illegal necessarily, where people with bulimia nervosa are more apt to do those things. And some of that goes together with bipolar disorder. When we talk about bipolar disorder, remember those clients can have impulsive tendencies. So if you have someone with bipolar disorder and bulimia nervosa, you're more likely to see these impulsive acts. In contrast to people with anorexia nervosa, people with bulimia are usually embarrassed or ashamed of their behavior. So we talked about how they try to hide it. They are often remorseful or disgusted with themselves after a purging episode. And they're generally open to talk about their eating habits while they're in treatment. I thought this was a great visual to show the difference between the body size of a person with bulimia nervosa versus anorexia nervosa. Clients with bulimia are generally close to an expected body weight for their size, but their weight may fluctuate up and down. So they're typically a normal weight or maybe even a little bit overweight because they're not necessarily restricting calories severely like a client with anorexia. The clients with anorexia will always be underweight because they have that severe calorie restriction. These are some of the complications related to starvation that I would like for you to look over. Now, these are things you're going to see in your client who has anorexia because they're the ones that are starving themselves and becoming emaciated from all that weight loss. So I just wanted to talk about a few things on here. I'm not going to go over every single thing. One thing is osteopenia, and that is when a loss of bone calcium leads to low bone density. This places a person at risk for fractures and osteoporosis. This is extremely important. If you think about our clients who have anorexia nervosa, it's early adolescence. And 50% of bone growth actually occurs during that adolescent period. So if you have someone with anorexia and they're not eating, they have low calcium, that's going to put their bones at risk for fractures for life. It's not something that they're going to be able to recover from and build up those bones to become strong later on. It occurs during the adolescent period. So it's very important that we diagnose this fast so that that doesn't happen. You may also have a decreased level of estrogen and calcium in women with anorexia nervosa. The estrogen plays a big part in bone strength as well. So if you have low estrogen, you're at risk for osteoporosis. One vital sign that's very important to watch for is bradycardia. Anorexia nervosa clients may have bradycardia as a response to starvation because their heart muscle can actually atrophy. It's not uncommon to have a client whose heart rates are in the 40s. And that's also due to the fact that everything in their body just kind of slows down due to that low metabolic rate. You may also see orthostatic hypotension, and that's a sign of dehydration and malnutrition. So watch for dizziness if this client is changing positions. Oftentimes, these clients will be intolerant to cold and be hypothermic. This is due to the decreased metabolic rate and also because they don't have any body fat on their body. So everything is starting to slow down. Their metabolic rate slows down to decrease caloric consumption. So essentially, in order to stay alive, their metabolic rate has to slow significantly. You may notice signs of dehydration, like decreased skin turgor, cold extremities, and dry mucous membranes. Amenorrhea is a word that means a sporadic or absent menstrual cycle. And this goes along with the decreased estrogen levels. So if you don't have enough estrogen in your body's not going to produce eggs and you're not going to ovulate. So therefore, you're not going to have a menstrual cycle. Sometimes this can resolve after treatment. So after the person is treated and they gain weight and they have adequate body fat and higher estrogen levels, their menstrual cycle may return. But in some severe cases, it actually never comes back. So then you have to deal with infertility on top of the eating disorder. One word you may not be familiar with on here is lanugo hair. And lanugo hair is like a fine baby hair all over the body. If you've ever seen a newborn baby, sometimes they're I call them like little fuzzy babies, little furry hair all over them. Especially premature babies will have this hair. And what it is that when your body will actually grow extra hair to try to trap in heat if the body doesn't have enough muscles and fat to keep the body warm. So think of it as like little peach fuzz all over the body. And the lanugo hair typically will be reversible after the person gains weight after treatment. These are some other signs and effects of starvation. People who have anorexia nervosa are typically very defensive. Remember, they don't want to acknowledge that they have a problem. So they're probably going to be very resistant to change and resistant to treatment. The cognitive changes I've listed on this slide are due to slower processing as a result of the starvation process. There are some complications related to purging as well. So specifically on this slide, we're talking about purging in relation to vomiting and laxative abuse. Sometimes a dentist or a dental hygienist is the first person to recognize that a person has bulimia nervosa, and that's because they'll notice that there's some erosion on the enamel of the back of their front teeth. They may also have swollen salivary glands, so I like to think of it as little chipmunk cheeks, little swollen cheeks, and that's from the constant throwing up. They may also have severe acid reflux and permanent damage to the vocal cords from repetitive vomiting. Think about if that acid is constantly coming from the stomach up into the esophagus, how damaging that can be. There's something called Russell's sign, and that's when there's calluses on the back of the knuckles where the teeth have rubbed against them while self-inducing vomiting. So if you suspect that a person may have bulimia nervosa, look at their dominant hand and look at their knuckles and see if there's any calluses on them. And that's a sign that they may be purging. Purging throws off the body's acid base, which is reflected in elevated bicarbonate levels in the blood. And laboratory values of low potassium, low chloride, and elevated bicarb indicate metabolic alkalosis. Let's briefly talk about binge eating disorder. So think about binge eating disorder as very similar to bulimia nervosa, but you don't have the purging behavior afterwards. So these clients are going to eat a large amount of food in about a 2-hour period. They're going to feel very out of control during the binge and very guilty or depressed afterwards. And it has to occur at least once a week for 3 months for diagnosis. This generally affects people older than 35, and these clients are likely to be overweight and obese, which makes sense, right? If they're consuming large amounts of calories, but they're not ridding themselves of it through purging, then they're going to gain weight. Binge eating disorder is the most common eating disorder in men, and studies suggest that it affects men and women equally, which is unlike anorexia nervosa and bulimia nervosa, which primarily affect women. As a whole, binge eating disorder is the most common eating disorder of all, which I've shown you on this graphic on this slide. Here I've listed characteristics and complications of binge eating disorder. I mentioned that these clients feel very guilty after binging. Typically, these clients are very depressed. They also oftentimes suffer from anxiety and substance abuse as well. You can see as the complications, they're related to people who have unhealthy eating habits and who eat a lot or who may be obese. So read through these and be familiar with them. Because eating disorders are diseases that not only affect a person physically, but mentally as well, we have to do physical assessments and psychiatric assessments. So to start with the physical assessment, vital signs are very important. Specifically, looking at orthostatic hypotension. So we want to look at this person's blood pressure and their heart rate. Remember that bradycardia might be present in someone with anorexia nervosa. Getting a height and weight is also important, and we want to measure their BMI. And remember the signs and symptoms that we talked about on the previous slides, and you're going to want to assess for those as well. Laboratory studies will most likely be drawn, specifically looking at a CBC, electrolytes, glucose, BUN and creatinine, the TSH level, and TSH may be decreased related to a lack of fat and cholesterol in the diet, so that's why it's important to look at. You're also going to want to do a pregnancy test, especially if you have someone who hasn't had a menstrual cycle in a while. We want to rule out pregnancy as a cause for their symptoms. Hypokalemia is the most common and perhaps the most deadly electrolyte imbalance because it can cause cardiac arrhythmias. So looking at the potassium level is extremely important. We also want to ask the client about their dietary and exercise habits. So, what kind of foods do you typically eat? How often do you eat them? Do you stick to a specific calorie intake per day? How often do you exercise? What kind of exercise do you like to do? Questions like that would help gain insight on their behaviors that they have at home. There are a lot of things we can assess psychiatrically. So first, assess their mood. How are they when they talk to you? Do they seem elated? Do they seem depressed? Are they willing to talk about their disease process, or are they very resistant and hesitant? We want to take a good history, see if they have any previous mental health diagnoses, any history of current or past substance abuse. Ask about their support system at home, who they live with, stress and coping patterns. When they get stressed out, how do they handle that? It's likely going to be not healthy, especially, they might restrict calories more if they're anorexic, or they might have more episodes of binging and purging if they have bulimia. We want to ask them specifically about their home environment and their peer and familial relationships. Are there any stressors there that we can take note of? We want to assess their thoughts about food and their self-image. See if they have any body image distortion. Are they seeing things that aren't there? As with any psychiatric illness, you want to assess for suicidal ideation. And if there is suicidal ideation, obviously we need to report that and do further assessments from there. There are screening tools that are used to help identify eating disorders. They are not diagnostic, so they're not going to diagnose an eating disorder, but they can help practitioners look at the results and be able to assess whether someone may have an eating disorder based off of their answers. And these questionnaires are answered by the client, and it helps us understand how they feel about food. They help identify specific symptoms related to an eating disorder and indicate a focus for their treatment. And I've posted one to the LMS that you can look over as an example. In order for a person to be hospitalized with an eating disorder, there are some criteria they need to meet. Hospitalization may be required if the person is less than 85% of their ideal body weight. So for example, if their ideal body weight is 100 pounds and they're less than 85 pounds, they would have to be admitted. Any kind of severe electrolyte imbalances or severe dehydration, severe cardiac abnormalities, so if they have a heart rate of around 40 beats per minute, that would be something we need to assess further. A low body temperature, specifically less than 36.1 degrees Celsius. Any kind of altered mental status, or if they're at risk for suicide. Failure to comply with an outpatient treatment regimen. And if they have bulimia nervosa, if they're just having out of control binging and purging episodes. There are a couple medications that are approved to treat eating disorders. For clients with anorexia nervosa and bulimia nervosa, fluoxetine is FDA approved for their treatment. And this drug is an SSRI, and it seems to reduce preoccupation with body weight. It's also shown effectiveness in preventing relapse in the later phases of treatment. And the fluoxetine is especially helpful with the comorbid conditions that come along with eating disorders, like obsessive compulsive disorder and depression. So the thought is if you can control the comorbid condition, that you can actually alleviate the eating disorder. It's important to know that weight loss may be a side effect of the medication, and that's something we definitely don't want to happen. So these clients may need to have their weight checked regularly. One drug that we try to avoid in patients who have bulimia nervosa is bupropion or Wellbutrin, because it's been associated with seizures in patients with severe electrolyte imbalances due to purging. So that may be something you read about and have questions about. So just make note of that bupropion is something we don't give to people with bulimia. For binge eating disorder, we can give Vyvanse, and I'm not going to try to pronounce the official name of that drug because I will butcher it. Vyvanse is actually a type of amphetamine or stimulant. It's generally used to treat ADHD, but it's helpful in treating binge eating disorder because it suppresses the appetite. So by suppressing the appetite, the thought is these people will have less episodes of binging. A couple of slides ago, I mentioned the criteria for someone to be admitted to the hospital for treatment, and these are what treatment guidelines we will typically follow for that person who's admitted inpatient. Now, typically people who are inpatient are those with anorexia nervosa that are severely malnourished. Typically bulimia nervosa patients and binge eating disorder patients can be treated in an outpatient setting. So these treatments are geared towards those with anorexia nervosa. And their treatment is focused on weight restoration, which is the number one goal. We also focus on nutritional rehab, rehydration, and correction of electrolyte imbalances. And while a person is inpatient, their electrolytes are going to be drawn every 1 to 2 days. So we're going to be doing those BMP or CMP labs, usually daily. We are also going to gradually increase caloric intake because refeeding is the most important intervention during the initial stage of treatment. Usually they'll start with a diet of around 1,500 calories per day, and then it will increase slowly to around 3,500 calories a day. These calories are going to be given over several meals per day. It's not going to be in like 3 meals that we typically give to patients without an eating disorder. Sometimes they'll break it into like 3 meals and 3 snacks, but that can vary based on the client and what they need. If a client is severely malnourished or if they completely just refuse to eat, which is very common in people who have anorexia, we may have to do an NG tube and do feedings that way. And we will do a liquid protein supplement, so things like Ensure, Boost, Pedialyte, and we will give them via tube feedings. TPN can be used. I have not seen this in practice, but in those that are severely malnourished who just completely refuse oral caloric intake, or maybe they keep pulling out their NG tube, TPN may be an option for them. Sometimes too, what will happen is that if a client has a meal on their tray, they are expected to eat that entire meal. And if they don't, then those calories have to be replaced via a liquid protein supplement. So like, let's say Ensure, which is an example I already gave. So what we would do is, let's say they eat their whole tray, but maybe they don't eat all of their mashed potatoes. And those mashed potatoes were worth 120 calories. Well, we would give them 120 calories in that protein supplement that they would have to drink to replace those lost calories. Oral electrolyte supplements and vitamins. So one example would be potassium we give quite often. Others may be phosphorus and calcium. They're also going to be on a multivitamin. It's important to maintain strict I's and O's. Obviously, we want to know everything that's going in their body and out of their body. A sleep routine is very important. Oftentimes, clients with anorexia nervosa have insomnia. And to establish a sleep routine actually helps them conserve energy and helps them gain weight. And no exercise is permitted until a certain amount of weight is regained. And that's kind of hard to keep track of and to kind of watch for, which kind of goes into my next point, to having a sitter at bedside. So we will want a sitter at bedside, and they need to provide close monitoring at all times, particularly close monitoring 1 to 2 hours after each meal to make sure they're not going to the bathroom and doing any kind of purging, throwing up. They should also be watching for exercising in the room. Sometimes these clients will run in place or do jumping jacks in their room. They're very creative in ways to try to help, burn calories and avoid gaining weight. These clients are not allowed to go to the bathroom with the door closed, and must remain in view of the staff member at all times. So that can be very intrusive. These clients are oftentimes very angry that they're being treated. They feel like they're in jail. They feel like people are forcing them to gain weight, and they're often very mean. We had a client one time who was extremely upset at the sitter in her room that she took her underwear off and just threw it at her because she was that upset at her. So that is not uncommon to see things like that. In the inpatient world, oftentimes the restrictions will start decreasing as the client demonstrates appropriate eating habits and as they are more cooperative in their care. So as we can trust them more, then some of those restrictions will be lifted. The daily weight is very important. We usually weigh these clients in the morning at the same time on the same scale. They can either be naked or in the same clothing. An average weight gain of 1 to 2 pounds per week is recommended. We talked about fluoxetine being a treatment medication for anorexia nervosa and also bulimia nervosa. This being an SSRI, typically start at 20 milligrams per day, and it can take up to 4 weeks to have an effect. It's really important as the nurse to provide a rationale as to why each intervention is done, and this will help you build trust with the client. Positive reinforcement is also helpful, so giving rewards when they are cooperative, like I talked about, loosening some of those restrictions as they show us that we can trust them, also helps them trust us more. Remember that power struggles may be common in the initial stages of treatment and refeeding, and this is due to the psychological aspect of the disease where that client doesn't believe they have an issue and they see the nurse as the enemy. Once a person is stable enough to be treated outpatient, there are some outpatient options we can have. Usually if they've been hospitalized, they will move to an outpatient treatment facility for additional treatment over a longer period of time. And as a whole, for clients with any eating disorder, the goal in outpatient treatment is to establish healthy and normal eating patterns. It's also important to look at a client's self-concept and self-esteem and kind of dig into that and try to understand why they feel like they aren't good enough and understand more about their background and their illness as a whole. Oftentimes it's difficult to treat clients with eating disorders when they are in a state of severe malnutrition because all their energy is going towards staying alive and not really using their brain to dig deep into these issues. So these type of therapies are going to be done after nutritional status has been restored. Family therapy is very helpful in clients who have anorexia nervosa, and it involves the family and kind of brings them in to help with the treatment of this client, helps resolve any kind of underlying stressors or family issues, and it allows the parents to be a support system and to learn about the disease process. It can also help the family become more aware of the signs and symptoms of the disease, which can help prevent future episodes of starvation. So teaching them about all those symptoms we talked about earlier. And family support and involvement has proven to greatly improve outcomes. Cognitive behavioral therapy may also be used. This is most effective in clients with bulimia, but can be used for any eating disorder. And this involves skills to deal with stressors. The main goal is to normalize eating patterns and support weight gain. So in order to do that, we need to help develop healthy coping skills to handle stressors. So instead of when something bad happens, going to McDonald's and binging on 10 Happy Meals, we can teach them positive ways to deal with their stress. So maybe like going for a walk, exercising in a healthy way, listening to music, things like that. And we want to help them change their distorted beliefs and thoughts that make them eat the way that they do. Clients with bulimia or binge eating disorder may be encouraged to keep a diary in which they record times that they binge and purge and the emotions that precipitated those events. So if we can identify what stressor led to the binge and the purge, we might be able to develop coping mechanisms to deal with that are healthy. Interpersonal therapy focuses on uncovering and resolving the developmental and psychological issues underlying disorder. So these are like really deep therapy sessions that will be done later when the client is healthy enough to really investigate their feelings about themselves. Might involve looking at their self-esteem and how their past trauma may have influenced their disease process. One other thing they like to do is nutritional counseling, and that's going to be for everyone with eating disorder as an outpatient therapy. And we can also refer these clients to support groups that may help them feel less isolated during their treatment. When we talk about refeeding, we have to talk about refeeding syndrome. And this is a severe electrolyte and fluid shift that can occur in the early stages of nutritional replenishment when a patient's caloric intake is suddenly increased. So when a person is in a prolonged state of starvation, there will be a decreased amount of insulin produced. Once we start refeeding this person and their calories start increasing, their blood sugar is going to increase, which is going to result in increased insulin secretion. This is because there has been a shift from the body using fat and protein as its fuel source back to carbohydrates as its fuel source. Once this starts happening, the cells need electrolytes to convert glucose into usable energy. So the body will increase their uptake. The problem is that the body already has a low amount of potassium, magnesium, and phosphorus in the serum. So once these cells start pulling more of those electrolytes into itself, the levels in the blood are going to drop dangerously low, even lower than they were before. And this can be dangerous because it can lead to things like cardiac arrhythmias and death. The clients who are at highest risk for refeeding syndrome are those who have a BMI of less than 16 and who have been in a prolonged state of starvation. So let's talk about some specific nursing interventions, and some of these we've already briefly hit on, but we're going to go through them one more time. Obviously, safety is our number one priority, establishing a safe environment for these clients. Severely malnourished clients must have their physical needs met before we can begin any kind of psychiatric treatment or therapies. Remember, we want to focus on caloric intake, gaining weight, stabilizing those electrolytes, and promoting sleep above everything else. Remember that you as the nurse need to enter in a therapeutic relationship and build trust. This is a very personal process for these clients. We want to be accepting, use positive reinforcements, avoid talking negatively about the client. Remember, they usually have low self-esteem to begin with, so we don't want to beat them down further and use negative language. Always provide a rationale for the interventions that you're doing. Be consistent in your reactions and don't enter into power struggles, which can be very difficult in the beginning phases of treatment. These clients are going to want to be in control, and we need to establish boundaries early on. Setting realistic goals about food and behavior is very important. Short-term goals might be things that are focused around weight restoration and compliance with treatment, whereas your long-term goals might be focused more on coping strategies and preventing relapse. So think about what phase of the illness this client's in when we're setting goals. The client might become frustrated if your goals are too large or too unattainable at that time. So we might have to step in and set realistic goals. Again, a big thing to remember is that a client with anorexia nervosa may see you as the enemy at the beginning of treatment, and that's because they're going to think that you're trying to force them to get fat. I've listed some long-term goals that will apply to clients who have any type of eating disorder. Obviously, we want them to have a more positive view of themselves and improve their self-esteem, establish healthy eating patterns, and learn about nutrition and how important nutrition is and how they can fuel their body appropriately. We want to teach them about exercise and how much exercise is important and the appropriate amount of exercise that they may need. We talked about developing coping skills and mechanisms to help deal with their anxieties. And an active participation in their treatment plan is necessary to prevent relapse. As far as a prognosis, people with eating disorders rarely seek help and are typically not motivated to change and often leave treatment. For bulimia nervosa specifically, it's underdiagnosed, and it's estimated about 25% of people with bulimia are actually never treated and never diagnosed at all. Some clients will recover spontaneously, while others have long-term complications and relapses. We mentioned earlier that bulimia nervosa has a higher rate of recovery than anorexia nervosa, and that's just because these clients' personalities are typically more willing to accept help and be open and willing to change and notice that they have a problem, whereas people with anorexia nervosa think that nothing's wrong with them. Clients with another mental health diagnosis have poorer outcomes. So these would be your clients with co-occurring OCD, bipolar disorder, personality disorders, and substance abuse disorders.